So, of course, the nutrients and how they're affected by kidney disease are our big focus. We want to, in all stages, maintain optimal nutritional status. But in stage 4 and 5, we're looking at assisting in the control of blood pressure, the electrolyte balance, the bone health, minimizing uremic symptoms, and as there are usually numerous diet restrictions related to the patient, we need the goals to be prioritized and individualized, specifically to the patient. So Roz is our 60-year-old female, who is apparently young now. Her height is actually 164 centimeters. Her weight's 108 with lots of edema to the thighs and probably at other places as well. Weight loss of 5 pounds in the last 2 months could be related to fluid. Her ideal body weight, with using a BMI of 23 to 28 for the slightly older lady, is about 62 to 75 kilograms. That's about 144% of the ideal body weight. So we adjust the body weight to about 83 kilograms. Using it in an outpatient setting, the Mifflin equation, we come up with about 1,500 calories with about 500 for weight loss. Using 35 calories per kilogram adjusted body weight, you get about 2,900 calories. So there's quite a big difference, and we really have to make sure that this lady has enough calories so that she maintains her nutritional status. You all know that in not enough calories, it leads to the body breaking down the tissues, the muscles, for energy needs. While blood pressure control and the use of ACEs have been shown to be very beneficial in delaying the progression of kidney disease, there's lack of convincing evidence that lower protein diets delay progression. So we rarely go below 0.8 grams per kilogram ideal body weight and up to 1 gram per kilogram, especially with those on high-dose steroids and those needing calories. Control protein to manage serum urea and phosphorus levels. And in our case, using 0.8 to 1 kilogram adjusted body weight, we end up with about 66 to 83 grams per day. And we aim for closer to 66. Sodium restrictions are used to control blood pressure and to reduce fluid retention. The latest guidelines to prevent high blood pressure are less than 100 millimoles per day or 2,300 milligrams. In patients with hypertension already, 65 to 100 millimoles per day or 1,500 to 2,300 milligrams. However, 1,500 milligrams is very restrictive and hard to achieve. Also, restricting sodium too drastically affects the patient's appetite. And remember, our aim is to keep her nutritionally adequate. Keep them eating. Additional sodium may be required when patients have salt-losing nephropathies occurring in non-glomerular diseases. So our lady Roz has about 66 to 83 grams of protein per day is what we want to see, about 100 to 130 millimoles if she'll allow us. And what we want to look at next is the serum phosphorus or the low phosphorus diet because of her serum phosphorus being 2.36, which is pretty high. So the target ranges for calcium, phosphorus, and PTH. As you can see, KDOQI and CSN and KDIGO all are basically opinion-based. So what we did in 2005, the MRP, nephrologists, pharmacists, dietitians met and reached a consensus. And these are our targets for the MRP: less than 2.6 in serum calcium, less than 1.8. You start diet if it's over normal. Start binders if it's over 1.8. And the PTH, again, is 150 to 300 target. Now, Our Lady With the PTH above desirable range, we start rocaltrol or calcitriol. In our case, the PTH is 188, so we don't start that at this point in time. We do, however, look at the diet, and the recommendations are to restrict phosphorus to 800 to 1,000 milligrams per day in stage 3 and 4 when levels are above 1.5, adjusted to protein needs. There are about 10 to 12 milligrams of phosphorus per 1 gram of protein, and in our case, Roz needs about 66 grams, or it will equate to about 660 to 792 milligrams of phosphorus. The binder Apocal, or calcium carbonate, is started when the level is above 1.8 with diet. And in this case, remember, her serum phosphorus was 2.36. Her calcium was 1.89. So binders provide extra calcium as well. What are the high phosphorus foods? Many of us know this already. The high protein foods, of course, and then we want to limit that. Dairy products, we restrict the dairy products to about a half a cup a day, or 1 serving per day. Legumes, nuts and seeds we want to avoid. Whole grain breads and cereals we want to avoid because of the high fiber, which is directly opposite to what we teach for diabetes, where we want them to increase their fiber to slow the blood sugar, etc. But we're almost teaching them the exact opposite once this starts to happen. Chocolate and beer get restricted. And food additives can become a real challenge. And more so lately because they're adding them to non-traditional foods as well. So why are they added? They are added to make foods creamier, maintain the juiciness of meat, prevent beverages from separating into individual ingredients, and accompany added nutrients as in calcium fortification. They also make foods last longer. What's the problem? Depending on the food choices, phosphorus additives can add 1,000 milligrams per day to the diet. Phosphorus additives are absorbed at 100% compared to 50 to 70% of naturally found in food. So it's more, the 50%, sorry, going just back a bit, 50% is more plant-based and 70% is more animal-based. So as phosphorus daily value is not listed, it's not required by law to be on there, it's usually not on there. But if it is, aim for less than 5% or 0 to 50 milligrams of phosphorus. Phosphorus additives in food, for example, it's really more important to read what is in the label than ever. Like I said, it's added to non-traditional foods. So baking powder is usually normally used in tea biscuits and bannock. You want to avoid that. Look at how much it's coming up to. Colas, the phosphoric acid, is a pH control agent, flavor enhancing. It adds about 44 milligrams. And in instant pudding, it's about, in a half a cup, it's about 350 milligrams of phosphorus. And if you remember the 800 to 1,000, if you have a cup of instant pudding, you're getting very close to that number of 660. Potassium is slightly elevated in Roz's case at 5.3. And we don't touch on potassium unless the lab normals, or unless it's above the lab normals. And the labs have been varying their normals. So at Health Sciences, we've got it 3.5 to 5.0. And we actually saw it rise in December and come back down. Just, I was checking labs the other day, it went up to 5.1 and then went back down to 5.0. So you have to really know your lab normals. Even in the hospital you work in, they keep changing them on you. When it's above normal, we look at restricting to 2,000 to 2,300 milligrams per day. Factors contributing to the hypercalcemia, medications, ACEs and ARBs, potassium-sparing diuretics like spironolactone, Septra, potassium supplements. Really make sure that the patient is not on slow K first. Insulin deficiencies, so if blood sugar is high, potassium is pulled from the cells into the blood. With acidosis, potassium is pushed from the cells and exchanged for the excess acid. And of course, salt substitutes, they like half salt, no salt. Half of the potassium is exchanged for sodium, so it's not providing any benefit. And of course, in diminished urine output or less than 1,000 milliliters per day. So if the potassium remains high even with diet, we look at a binder, a KX-late. Don't take it with orange juice, which is a high potassium juice. And a lot of people are taught, especially with diabetes, that when you have a low blood sugar, take it with orange juice. Take orange juice and get your blood sugar up. Apple juice and cranberry juice is going to be fine to bring your blood sugar up. Don't take the KX-late with the orange juice because you're just doing the opposite. Also, we look at making sure that we want to prevent malnutrition. So we look at things that would help when a person loses their appetite, when uremic symptoms start. Weight loss due to anorexia and or nausea. Many patients develop an aversion to meat, different meats. I can't even pin one down. But some people hate chicken, some people hate red meat, some people fish, it's all different. But what we do is take a look at the different nutritional supplements, and Nepro and NovaSource Renal have the lowest amount of phosphorus and potassium in them. Beneprotein will give you straight protein if that's what you're looking at to increase the amount of protein in the diet without increasing the calories. And then the vitamins, supplementation usually not needed if the intake is good at stage 4 and 5, and especially in Roz's case, she's not eating. Intake is probably pretty bad. We look at getting away from over-the-counter multivitamins. Vitamin A is not recommended with advanced renal failure due to decreased excretion of the retinol-binding protein and chance of toxicity. And we also know that over-the-counter multivitamins contain nutrients that we individually adjust for in kidney failure, such as calcium, vitamin D, iron, and some that don't need supplementation like phosphorus. So Replovite is used as the designer vitamin for kidney disease. So our goals for Roz are 66 grams of protein per day, between 100 and 130 millimoles of sodium per day, about 50 to 60 millimoles of potassium, and phosphorus between 800 and 1,000, although for her it could be a little bit less based on adjusted for protein intake. The fluid is usually not restricted in stage 4 to 5, but with her edema, we may be looking at restricting it sooner. And also with heart disease or liver disease where the fluid builds up in the body, that would be also something that we would be looking at as well. We know for sure that she's been seems to be referred late. She's 60 years old. She's got a lot of habits that she needs to break. Salt is one of the first ones that people have the hardest time with. And so one step at a time, we work with her, and because we're an interdisciplinary team, we'll see her more often and we'll have more impact on changing the diet. And that leads us to the pharmacist's role. Thank you very much.